Thanks for joining me. Today, the topic that I'd like to discuss is transitions and transfers, mostly between one facility to another facility, but also within hospitals, this happens as well. The reason this is an important topic is because there's multiple studies on this and show that that's when things fall through the cracks, right? That's really when you have these opportunities for important information to not get communicated from one facility to another facility. Or like I said, even within the same typically hospital, things can get lost. By way of example, I had a loved one that was in a hospital recently for what I was quite certain was a reoccurring pneumonia. And I had been contacted and I said, well, they'll probably just get some antibiotics and cut this fellow loose in the afternoon. And they decided to admit him. And when he was, they did chest scans and they decided to admit him. So he went from the emergency department to the med-surg unit within the hospital. The scans that came in right after his transfer said probable pneumonia, but no one from the new unit in the hospital, in the med-surg unit, looked at the scans. And so this poor fella was almost 24 hours before receiving any antibiotics. That's bad, right? Fortunately, it was caught by a physician family member, but many people don't have physician family members. So this kind of thing can happen even in good hospitals. It's the transition from one place in the hospital to another. This is more pronounced in the universe I inhabit when a person goes from a hospital to a nursing home, or sometimes from a nursing home to a hospital. That is an opportunity for the ball to get dropped. Now, here's the thing, too, when you have an elderly population that's coming from a hospital to a nursing home, generally speaking, many of them have cognitive impairment. Now, the problem with cognitive impairment is it can be stable at times if you're in the same environment. When you switch environments, it can be aggravated because it increases confusion. I used to have a job where I traveled all the time, and I would wake up in Marriott courtyards all over the country, and I didn't remember what city I was in sometimes until I looked out the window because they all looked the same. So when you have cognitive impairment, that confusion's already there. You're already struggling with activities of daily living and day-to-day type activities, and now you're moving into an entirely new environment. It can be very difficult. In fact, they have a phrase for it, and it's called transition trauma, right? Transition trauma. So this is of particular importance because this can increase your risk for falls. In particular, it can increase combative behaviors, and it can increase confusion. So these transition periods are ones where healthcare providers have to be of heightened vigilance, in particular people with cognitive impairment. I'll also tell you this, this is also documented in studies, but even elderly people that do not suffer from Alzheimer's or dementia, if they have a major surgery with general anesthesia, like a hip replacement or a knee replacement, they will also frequently exhibit symptoms of dementia for a period of time. Now, typically it will reverse itself, but not always. So many times you'll have people that are cognitively intact who go into the hospital for a hip replacement, and they come out of the surgery and they're just off. It's clear to everybody that something's going on. When they transition to a rehab, that may not be cleared up. So nursing homes, and especially when they're providing rehab functions, have to be very vigilant when dealing with new admissions. So what I want to do is I want to talk about the process about when a person comes into a facility, because that's universal no matter where you are. The time periods may be slightly different, but for the most part, it's pretty much the same. And the family really should be involved in this process. You, as a family member, know your loved one better than anybody else. And so if they have quirks or they're off or they're not on their best game, then the facility needs to listen to you when you tell them that. All right. So let's talk about a typical scenario where a person has a fall at home. They live independently, but they have an injury at home. They go to the hospital for surgery. Now, I don't know about anybody else, but when I first heard hip surgery and I saw it was involved, I thought you'd be in the hospital for a month. And the reality is they do the surgery and they start getting you to walk right away. And they want to discharge you within 2 to 3 days. And the reality is most people don't know anything about nursing homes, so the social worker will come to a family member with a list and say, listen, here are the rehabs nearby. The doctor's indicating that rehab is going to be helpful. So which each place you want to send them? And that's usually how it happens. Most people aren't prepared for it, and they typically pick the places that's closest to them because they want to go visit their mom and their dad or their spouse. Now, this is going to be a transition from a hospital to a nursing home. Here's what needs to happen. The social workers will line all this up in advance, right? The transfer, the meta-transport, all that. At least they should. That nursing home that's going to get this new resident is going to be able to ask questions of the hospital and get as much information as they can about that resident before they even get in the ambulance, right? Because they know that they have a lot of information that they're going to need to acquire very quickly in order to provide the best care for that person. What will happen then is there's a form, almost, well, in New Jersey, we call it a universal transfer form. It's the same in all facilities, but each jurisdiction will have something akin to it. And they're going to come with important documents. Usually they're going to come with maybe a history and physical that's going to explain what happened, or a discharge summary while that person was in the hospital. And they're also going to come with orders for medications and treatments that are going to come along with the person. And sometimes there's other documents as well that new resident should come to the nursing home with. And when you have an effective handoff, it's going to have a completed transfer form, all the documents that are important. Well, I should say all the documents that are going to convey the important information about that person, so that this nursing home is going to get this person and they're going to be able to take care of them right away. Now, when you come into a nursing home, it doesn't matter what shift you come in on, there is going to be a comprehensive assessment, and it needs to be completed by a registered nurse. That's almost universal in all jurisdictions. There's different types of nurses. There's registered nurses, which have a full nursing scope of practice. They can do anything a nurse can do. Then you have what are called LPNs. They're licensed practical nurses. In New Jersey, that's what they're called. In Pennsylvania and other states, they're called licensed vocational nurses, or LVNs. But that role is basically the same. They don't have the education or training that a registered nurse has. So they are not allowed to do physical and cognitive assessments in almost all jurisdictions. I can't think of one where they can. So what should happen is a registered nurse is going to complete a head-to-toe assessment of all new residents, and they're going to develop what's called a baseline care plan, right? And what this is it's basically something that's going to cover the time from admission until the formal care plan is drafted. All right. So a baseline care plan is going to cover all the important things, for example, fall risk, skin breakdown, cognitive status, activities of daily living, and they're going to draft this document right away, because you can't not have a care plan. So all residents will have a care plan at all times. But understanding that it may take a little while to get a comprehensive assessment, that this initial head-to-toe assessment is going to be the basis of the baseline care plan. Now, in some states, there is a time period that they have to draft a formal care plan within, but more importantly, every new admission to a nursing home is going to get a comprehensive assessment that goes to the federal government, and that is called a minimum data set, or MDS. Multiple disciplines are going to participate in this process. The social worker will, dietary, the registered dietitian is going to have a part in this, nursing is going to have a part in this, and therapy is going to have a part in this. And this assessment is going to have to be done in 14 days under the federal regulations. So that's important because that assessment is going to typically be the assessment that is the basis for the formal care plan. So you're going to come in, there's going to be a baseline care plan done on a head-to-toe assessment, but shortly thereafter, the facility is going to draft the minimum data set. Now, practically, the minimum data set's a computer program, and as you go through this standardized assessment, it's going to flag specific areas based on how they're answered. So, for example, if a person is at risk for skin breakdown, that's a question, then it's going to flag skin as an area that the facility has to make a care planning decision on. So it assists in this care planning process. And that's how it all works together. So at a minimum, at 14 days, they're going to have this minimum data set completed, and then that will be the basis for the formal care plan, which should be clicked on shortly thereafter. Now, in most states like New Jersey, care plans have to be written by registered nurses. Now, usually what happens is there's a care planning committee, and they're going to review a resident and all their needs, and they're going to look at those assessments and determine what are the focuses that they need to address. You know, they have to give timelines, right, for the next 90 days, no skin breakdown, something along those lines, and then list the interventions or what they're actually going to do to prevent a bad outcome with that given focus. Now, care plan is a really important document. There's federal regulations on care plans. I can't imagine a state that doesn't have a state regulation on care plans. But most importantly, they have to be specifically tailored for that person. These are not, boxes to check off or one size fits all. It has to be specifically tailored for the needs of that resident. So it requires an approach to care that oftentimes involves the family members. And sometimes the government, sadly, has to direct this, tells the facilities that you have to involve the family. So, for example, if you're suffering that transition trauma and a person is combative on transfer, say somebody who is hospitalized who has dementia and it's been aggravated because of a surgery, right? Now, it's probably going to come back to their baseline, but right now, they're in a dangerous spot because they're combative, right? Then the care plan should address that issue, that a resident can be combative. The interventions could be things like approach this resident by using their first name, only approach them from the front so they're not startled, use a soft, calm voice when speaking to this resident, maybe give them chocolate, whatever it is to calm them down, then that's what needs to happen, right? But they should also be engaging with the family and say, well, mom is combative right now. What would you recommend, or what tools have worked for you in the past, or what do you think about this? Or sometimes one of the interventions may be calling the family, right? If someone is being difficult, to call the daughter if mom is not following direction, or won't get a shower, or whatever it happens to be, right? This period of time right before discharge until the time this formal care plan is drafted is really important. It requires a lot of vigilance and attention by facilities and staff. Keep in mind, too, it's also difficult because the aides and nurses, they generally don't know this person if they're new to them. And listen, some of these folks have quirks. For example, a common condition with dementia is sundowning. That is when it gets dark, they get agitated and walk around. They may not know this person sundowns yet, right? So you have to really pay attention to your new admissions to be sure you're not missing something critical like that. Because if a person is at high risk for falls and isn't using the call bell light to ask for help and needs assistance, but they're just getting up, then that's a problem, and the facility should know about that, right? Sundowning is not an uncommon condition, and most residents fall while going to the bathroom unassisted without using the call bell. So this period of time, if you are having someone admitted to the nursing home from the hospital, is really important. Now, when a person goes from a nursing home to a hospital, that's there's not as much time beforehand because it's usually an emergency. So, generally speaking, there's a few documents they're going to go with, including maybe their orders or certainly the universal transfer form. But there's generally not um, the same amount of time to prepare for the transfer, like going from the hospital to the nursing home. So not as much goes with the person. Oftentimes there are discussions though on the phone between the staff and the hospital. Like for example, I had one recently where the hospital actually wrote the nursing home didn't know what happened to this person. That's why they're getting sued in part. But generally speaking, that's unconscionable. You should actually know, you should 100% know your residents, and you should know why they're going to the hospital and what happened to them. Within transports between units in the hospital, as I gave the illustration, that personal story in the beginning, that does happen. However, like I said, they're all operating off the same computer system. So there are, in my experience, less errors in that department. The big place where I see the problems is when the person goes from the nursing home or from the hospital to the nursing home. The last thing I want to mention, though, is the one document that you come from the hospital to the nursing home with is your orders. And this includes medications and treatments. And the nursing home is required to what they call reconcile the orders. That is, they have to call back to the hospital and go through all the medications and all the treatments to be sure they all have them. Now, I have seen this fall through the cracks as well. I had one where there were no antibiotics, and it was caused a very catastrophic ending for my poor fellow. But at the end of the day, that's another one. So if you know what medications your loved one is on, or you get a printout from the hospital when you go to the nursing home, you can ask to check yourself and be sure that they're getting all their medications, especially if they have really important ones like antibiotics or something you know has been prescribed at the hospital to treat a condition that they're rehabbing for. You can also see and ask and say, I want to see their orders and I want to see their medication administration record, and make sure that they've done their job and reconciled the orders to be sure that the transfer from a medication and treatment standpoint is as smooth as the one for their physical and medical needs. I hope you found this interesting. At this extent, if you do have someone going through this process, you are absolutely 100% entitled to involve yourself in that process and be sure that your loved one gets a smooth transfer from one facility to the other, and reduce that transition trauma and hopefully have a safe transition. Thanks for your time and attention today, and have a great day.